Good afternoon, everyone. I'm Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we want to welcome you to today's webinar. Dr. Wall is a little bit delayed, so we might have a couple-minute delay on starting of the webinar, but I'm going to go ahead and get started with information regarding the CEUs and the evaluation. Right now, you're in listen-only mode. So you're only able to communicate using our chat and Q&A panel. So if you need to ask a question, please feel free to use the Q&A panel, and the presenter will address your questions as he's able to. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen, and those options are posted in the chat panel. If you are experiencing poor audio, you can always use your phone to call in. Try rejoining the webinar and use the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. So again, if you are participating with your phone, please be sure to stay logged onto the computer so you can view the slides to get credit for attendance. The recording of today's webinar will be available within 30 business days along with the material. And here is actually the call-in number and access code, which I have posted in the chat panel. Our recording and the materials, again, will be in our resource library, and it will be available within 30 business days. One helpful hint is you might receive a display that looks like this, and it's an error message. So just ignore it, hit play, and enjoy. And again, it's the recording and PowerPoint will be in our Resource Center training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families to help participants track credits earned through attendance. We host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign into your account to complete the evaluation. If you have not created a profile in FADA, you will need to create one to be able to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. It's very important that you attend the full webinar to receive credit. Completing the evaluation is also necessary to receive CE credits and to access your statement of credit. The evaluation will close at midnight on Tuesday, June the 30th. So 30 days from that, your credits should post, or up to 30 days. 1 to 2 continuing education credits are available for participating in today's webinar. For persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed to the Florida Certification Board. If you are a licensed healthcare practitioner, you want to make sure you include your Florida license number for reporting to CE Broker when you register with our site. And please note that WebEx does monitor your departure and arrival, and they do provide us a report upon completion of the event. So again, it's very important that you attend the entire webinar. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. And with that being said, I'd like to welcome our presenter, Dr. Walls. He specializes in emergency medicine and lives in Fort Myers, Florida. He is a member of the Florida Society of Addiction Medicine, serves on the board of directors for the Florida College of Emergency Physicians, and is a practicing emergency medicine physician. During his service with Lee Health, He served as the medical director for opioid use disorder treatment. Here, he initiated MAT in the ED for patients suffering from opioid use disorder and then connected them with outpatient addiction treatment. Over the last 4 years, Dr. Wall has helped to craft local and state legislation regarding the opioid crisis. In 2015, Dr. Wall spearheaded a naloxone distribution program for his EDs, and in 2018, Wall initiated a buprenorphine induction protocol for the emergency departments at Lee Health. Dr. Wall now travels the state to educate other providers and community leaders on the rational prescribing for acute medicine, alternative therapies to opioids, harm reduction strategies, and medication-assisted therapy induction for opioid use disorder patients. He is beginning to start his own MAT clinic in Southwest Florida as well to better serve his community's population. Currently, he is initiating an office-based practice for MAT treatment of patients via telemedicine throughout the state of Florida. And one interesting fact about him is he's an FAA private pilot with 1,600 hours experience and pilots his own twin-engine aircraft throughout the Southeast. He also enjoys boating, sprint triathlons, and meditation practice on his free time. Dr. Wall, are you there?
I'm here.
Okay, well, welcome. And if you're ready to present, we're ready for you.
I'm all set. Yep. Okay, so first of all, thank you for everything you folks do in the addiction treatment community, and thanks for being here. I see there's quite a number of participants. I do a pretty good job of actually looking at the Q&A, the questions, and the chat, and I actually answer as we're going. So please feel free to interact. It makes for a bit of a better presentation and sort of interaction. I'm just going to start a timer. We're going to go for about 40 minutes, and then we take an intermission, and then we do another 40 minutes, and then some questions and answers if necessary, and just some resources, and you'll get my contact information as well. So let's get started here. So the purpose of this webinar is mainly to increase your knowledge on what the federal government has done to further allow us to engage patients with opioid use disorder and access MAT, mostly via telemedicine amidst the COVID-19 pandemic. Obviously, some states are actually pulling back due to increases in cases, so I don't think this is going away anytime soon. And so we're going to learn how best to continue getting treatment to our patients, because it's probably more important now than ever. I don't have any financial disclosures. I'm not paid by any company. I'm not paid by any company that makes methadone or buprenorphine. We'll talk about those heavily. Just for those of you that are on the call and might not know specifically what buprenorphine is also known as Subutex or Suboxone. So as I talked about, the goals for the webinar are really reorienting medication for opioid use disorder to meet the aims of social distancing. I'm going to try and sort of implore you or get you to maximize your use of telemedicine and or telephones. We're going to talk about that specifically. And that will increase your access to buprenorphine and methadone for your patients. I want to talk about how to digitally implement peer support and counseling support as well. And then most importantly, I don't want us to forget about our harm reduction strategies. And the main ones here in Florida that we're sort of used to providing is naloxone. And I'm going to give you a few options on how to increase your access to naloxone as well as your patient's access to naloxone. So let me just fix something on my timer here. Auto lock. All right. Sorry. Okay. Lastly, we're going to talk about the policies that support these objectives and what are the federal agencies that actually supported these change in policies specifically. Okay, so when we talk about patient issues concerning COVID-19, we're really talking about what is it that makes our patients that we treat and engage with opioid use disorder or substance use disorder more susceptible in this pandemic. And the issue really is that there's much worsening financial loss as far as financial despair secondary to loss of income and or loss of health insurance secondary to job loss. That sets folks up for sort of a terrible spiral that ultimately leads to worse deaths of despair. I want you to walk away from this lecture with the ability to discuss what are deaths of despair and what predispose people to deaths of despair. We're going to talk about that. Obviously, folks who are isolated in their homes are living with worse triggers. We're going to talk about mothers and pregnant moms as well, and some increase in domestic violence. There's less community support for them. There's a higher risk of incarceration and a higher risk of contracting the virus if they're incarcerated. The main three super spreaders, everybody thinks it's hospitals, it's actually not hospitals, are meatpacking industries, prisons, and skilled nursing facilities or nursing homes, known sort of in a more colloquial manner. So what about the drug supply? If you have a regular dealer and then that dealer and that supply is disrupted, you're going to go to somebody else. When you do go to somebody else, there's a higher incidence for the possibility that the drugs you're obtaining have a higher degree of fentanyl in them, and you're more likely to have a fatal overdose secondary to you're just not used to the drug supply that you're having or getting exposed to. What about withdrawal? Well, of course, if you can't get the medications or the illicit drugs that you're used to, you're going to suffer withdrawal. That's going to send you into a worsening situation where you're going to seek out probably other substances and another setup for fatal overdose. And then, of course, if you're isolated and you're using alone, some of our harm reduction strategies are actually educating folks on how to use more safely, and that is by using near folks that are also users so that somebody can potentially revive you should you get into trouble. And so that's not around anymore. And then, you know, the healthcare access, it's primarily worse in many ways, but somewhat better in others as far as telemedicine is concerned. So again, we're going to try and encourage you to adopt that in your practices. And then, of course, we're going to continually harp on the systemic and social stressors that are really much worse within COVID-19, and that causes this exacerbation of your substance use triggers and the increased need to self-medicate. Many folks, you know, that are familiar with alcohol sales recognize that alcohol sales immediately jumped from 55 to 65% throughout the nation. And what does that tell you? That tells you that, I'm using air quotes right now, but, you know, normal folks, because we stigmatize addiction so much, we tend to think that people that use alcohol to self-medicate are that much different. But frankly, it's not really all that different. And if, quote, normal folks are using alcohol to self-medicate, those that are addicted to opioids are obviously going to increase their self-medication as well. And then, as we discussed, there's definitely a decreased access to harm reduction. So there's no naloxone available from their usual sources. A lot of states have active, robust syringe exchange programs, and those aren't functioning at a high level anymore with COVID and the shutdowns. And then, of course, the physiologic factors of the patients that suffer from opioid use disorder. And that is many of them have COPD or chronic obstructive pulmonary disease. These respiratory and pulmonary issues make them more susceptible to a worse clinical course with COVID. Many of them are smokers, up to 65%, including vaping. We think there's some correlation between, you know, heavy vaping use and worsening lung infections with COVID. And then, of course, many of them have hepatitis and HIV secondary to IV use and IV transmission. and this makes them immunocompromised and a little more susceptible to viruses in general. So I want to focus a little bit on the roots of addiction. I often put this slide up saying, quote, we don't have an opioid problem, we really have an addiction problem. If you can all imagine while you're watching or listening, the opioid epidemic as a tree or very sort of ugly, destructive weed or bush. Essentially, what we're doing when we provide MAT, it is causing survival and causing long-term survival, and we're okay with that. But really, we're just kind of trimming the branches and the leaves when we engage patients with MAT. We're not really addressing the roots of the disease process. And these two economists, way down at the bottom here, it says Deaton and Case, Angus Deaton and Ann Case. They just came out with a book in 2020. You can get it from Amazon, Deaths of Despair and the Future of Capitalism. And the book is new, but their theory is probably since 2015, if you Google deaths or diseases of despair. The reason they came up with it is that we recognized over the last 3 years that life expectancy had fallen. And that's the first time life expectancy had fallen since 1918, which incidentally was the Spanish flu. And so we said, what is this? What is causing this reverse in life expectancy? And in fact, it's diseases or deaths of despair. That's 3 things: drug dependence, which is obviously mostly opioids, alcohol dependency and deaths associated with alcohol dependency, and then frankly, suicide. And why is it so prominent now? It's secondary to these negative adverse social determinants. So I don't have a slide on this, but I want you to walk away with 3 new terms: diseases and deaths of despair, number 1. Number 2, negative adverse social determinants. And then number 3 is adverse childhood experiences, or ACEs, ACEs. And what's happening is negative social determinants have become prominent. These are the conditions with which we are born, grow, live, and work. And if you imagine in the 70s and 80s, folks could get out of high school, not get a college degree, and have a job within the steel mills or the coal mines and have good employment. They had high wages. They had a really nice standard of living. And then they also had plenty of benefits, retirement and health care benefits. And what happened is when we got away from factory work and industrialization, if you will, and more into technology, these jobs sort of declined. And at the same time, opioids became very prominent with Purdue Pharma pushing opioids as they were for chronic pain or even moderate to minor pain. And so what happened is there was a lot of despair with the loss of this work. With that became worse childhood trauma, marital discord, concurrent mental illness, and there was a lot of isolation. And so that's loss of connection with others. And what happens when folks are isolated? They feel helpless. They're more likely to engage in risky behaviors, excessive alcohol use, substance abuse, domestic violence, and they forego necessary health care. So that really sets up a perfect storm. And if you look at what's happening now with our millennials, these are folks that are born from 81 to 1996. The evidence shows that they're much more likely to die prematurely from suicide and drug overdose than any previous generations were. And drug-related deaths among 18 to 24-year-olds have more than doubled from 2007 to 2017. And these alcohol-related deaths in this age group, so we're talking about 18 to 24-year-olds, rose by 70%. And suicides by 35%. So essentially, the literature has come to prove the theory. These folks came out with the theory. Karina put up their book up top in the chat, and you can download it as well. I believe it's even on audiobook now. And millennials have even suffered a double rate of anxiety disorder compared to baby boomers. And so why is that? Well, millennials have honestly been called the bad luck generation. It sort of started in 9/11, and then we had 2 wars, prolonged wars, We had 2 financial collapses, as well as this current COVID issue. And then, of course, the high prevalence of opioids has, again, really come together in this perfect storm. We have also had incredible rising healthcare costs. This rise of the gig economy, that means I actually didn't know what that meant when I was reading this fantastic article from The Atlantic. But the rise in the gig economy means that a lot of corporations are actually using independent contractors and freelancers. So these young people actually do not have the benefits that they had with those more stable classic jobs that were present in the 80s and the 90s. And when you have a poor job satisfaction, your job gives meaning and purpose to many people, then your life satisfaction really suffers. And so also with the prominence of social media, you know, this quote is really quite prescient. It's quite good. We have our blooper reel in our own heads. We have that negative self-talk, and then everybody else's highlight reel in the palm of our hands. And so there's a lot of self-doubt, depression over it, and really, I just was reading a question. I got a little bit distracted, but really it just culminates in making the millennials the most susceptible. And there is evidence that Generation Z, which is just after the millennials, are suffering as well. I have a question from Mary Butler that says, with isolation being so detrimental to addiction, what are your thoughts on telehealth related to the more serious treatments of addiction? Well, Mary, that is absolutely the purpose of this talk, and I'm glad you highlighted that. We're going to share all of that. My thoughts are is that it's imperative to implement telehealth, and in fact, with the government easing these restrictions on prescriptions for MAT and methadone, you're going to see quite well how you can increase the use of telehealth. So I think it's profoundly important. Thank you for that question. If you look at this slide, it's a little tough even for me to see on my laptop here, but essentially what it's showing you, and the point I have of this is showing emergency department visits in the Northeast. The solid black line is total visits. Down here at the bottom, it's February, and over here it's March 28th. And you can see this dashed line, the heavy dashed line, is opioid use disorder patients. So opioid use disorder patients come into the emergency department, and we actually utilize the emergency department now as a touch point to engage these patients. And these patients are not coming to the emergency department anymore. Does that mean that they're not suffering from opioid use disorder anymore? No, absolutely not. It just shows you the isolation, just as Ms. Butler pointed out, is quite profound. And of course, they're not even seeking care anymore in our safety net setup, which is the emergency department. And if you can imagine, you know, if they're not coming to the emergency departments, they're probably not going to primary care clinics, and most likely not to their OTP or methadone clinics as well. So let's just briefly talk about pre-COVID. So before COVID showed up, what was the regulation of MOUD? And by the way, I use MOUD because in the addiction treatment world, we're sort of moving away from the use of MAT. In other words, medication-assisted treatment. We're trying to say that it's not really an assisting of a treatment. We really are trying to make medication the primary modality with counseling and peer support to buttress and support the medications. Again, I want to reiterate over and abundantly that I am not saying counseling and peer support are not needed. In fact, they are really, really important and ideal when combined with MAT. But the newer term is medications for opioid use disorder, so MOUD. I'm going to use them interchangeably, but that's just so you understand and maybe come away with a little bit better understanding of why that occurred. So, was it easy to get these medications for these patients before COVID? Absolutely not. It was profoundly difficult for them to obtain. It's one thing that FADA and DCF has worked on is trying to expand access to MAT. It's how I got involved. I began expanding access to our emergency departments, hoping that our primary care and OBGYNs would follow suit. It's very, very slow going and somewhat frustrating, but I'm quite optimistic. Anyway, because of these regulations on buprenorphine and methadone, only about 1 in 5 individuals who has opioid use disorder actually gets any specialty treatment. And then any specialty treatment clinics, only about 35% of those are offering all 3 of the FDA-approved medications, namely buprenorphine, methadone, and naltrexone or Vivitrol. And so, we're really woefully under treating patients with what is now determined to be the gold standard of care. And a lot of times it's hard to get social governments and community task force to buy into it and the medications because of stigma, number one. And number two, a lot of them are worried that they'll be misused or sold or diverted. So what is drug diversion? If many of you don't know, drug diversion is if I get a prescription for a medication and I sell it, that's diverting that medication. If I get a prescription for a medication and my 5th grade nephew gets into it and gives it to other 5th graders in his science class, that's also diversion. So just a note on diversion of buprenorphine specifically, when it is diverted, it's often diverted for exactly the reasons that it's made, and that is so other folks on the street avoid withdrawal. So I am a proponent of saying I'm not really concerned with diversion of buprenorphine. If it gets into somebody's hands and saves their life, I'm very comfortable with it being diverted. And what about pre-COVID buprenorphine? I hope you all are familiar with this huge barrier called the X waiver. The X waiver is an 8-hour online course that any physician who has a DEA license to prescribe all of the most potent opioids possible. If you want to prescribe this very safe, incredibly nicely pharmacologically designed medication called buprenorphine, you have to do this 8-hour course online. And that's a real impediment for many physicians. I'm embarrassed to admit that, but that's the truth. And they just won't do it. And so basically less than 7% of all physicians who have a DEA license are actually X-waivered. We've tried in vain to get rid of the X waiver because we feel it's a huge barrier. It even barriers how many patients you can treat at one time. So in the first year, you can treat 30 rolling patients, which means, if you give a patient a prescription and then that patient leaves your practice, you can actively treat another one, so it goes down to 29. And then if that patient leaves your practice, it goes back up to 30. So it's really only for how long the prescription lasts. So you can only have sort of 30 rolling treated patients in your first year, 100 in the second year, and then you have to apply and that cap expands to 275 and it maxes out there for the next year, the years following. And with pre-COVID buprenorphine, it's important to point out you could only initiate this medication after conducting an in-person visit. What about pre-COVID methadone? Well, it's highly regulated by federally authorized OTP programs. You can't just start a methadone clinic. You have to be authorized and clear a bunch of hurdles to do so. Many clients that go to methadone clinics, of course, they have to show up every single day to that clinic, and that's a real barrier for many patients. And then take-home doses are strictly limited. And obviously, these regulations conflict quite a bit with social distancing practices, and they really pose a threat to the health and safety of anyone with opioid use disorder. And frankly, early on in this crisis, my friends in methadone clinics were calling me for PPE. So it's really a risk, to the providers as well. So what has changed? And here's really the answer, or the beginning teaser answer for Ms. Butler's question. Mainly, it's relaxed telehealth regulations. The federal government, and I'm going to show you those in the next slide, maximized the use of telemedicine and even telephones to allow treatment to be initiated specifically for buprenorphine and continued for both buprenorphine and methadone. The DEA has relaxed prescribing regulations, and they've promoted flexible access to buprenorphine and methadone, even including home delivery. And then they've, of course, Medicare, Medicaid, CMS, SAMHSA has recognized and addressed the importance of digital counseling and peer support. We're going to talk all about that. So here's the myriad of four different agencies just on the left. It looks like a complicated slide. It's really not particularly complicated. It's the Substance Abuse and Mental Health Services, or SAMHSA, the DEA, the OCR. You don't hear about this one very often. It's the Office of Civil Rights. It's what enforces HIPAA. And then you have CMS, which is the Centers for Medicaid and Medicare Services, and they're the payers. They're the federal government payers. And so what have they changed? If you look all the way over to the right, SAMHSA has extended take-home doses for methadone. They've clarified that CFR, 42 CFR Part 2, if you're familiar with that, it's very restrictive on sharing information if a patient is in a substance use disorder treatment facility, and they've made some emergency exceptions for that and clarified that. The DEA has allowed for delivery of medications. The DEA has also allowed for telehealth exceptions for inpatient visits. We're going to talk more about that. So you can initiate buprenorphine via telehealth and even telephone. You can write controlled substances via telehealth, which is a virtual care. You can't do it specifically with the telephone. And then the Office of Civil Rights has basically relaxed HIPAA so that we can do Zoom calls and other formats that are cleared and specified very specifically in black and white. And we don't have to be concerned about HIPAA with these modalities. So what's really needed for successful delivery of telehealth MOUD dispensing? Well, you need a sufficient capacity of your eligible providers, those that are X-waivered or DEA licensed. You need the technology both on the patient's end and the clinic's end. That takes a little bit of financial and or technical support. I had a question that was asked in the earliest webinar that said, you know, what about a patient that doesn't have a phone? That's an excellent question. I'm not sure that Florida is doing it, but other states are figuring that out and giving the patient a phone simply just for the purpose of receiving their medication-assisted treatment. You obviously need some guidance concerning what's private and what is allowed with HIPAA and 42 or Part 2, 42 CFR Part 2. It's always a tongue twister for me. And then you need to know, you know, can I bill for these services from Medicaid and Medicare, and will they pay them? And the answer is yes. And then you really need to coordinate with your staff on what are the updated telehealth workflows in delivering MAT to these patients. And that's as important as anything else in this talk. I don't have specific protocols, but I'm going to show you resources where you can find protocols, and that basically divvies up the work or delegates the work to specific providers. You know, hey, the MA in the office gets the consent form, goes over the patient a dry run with the telehealth, and provides sort of prepping of the patient and asking if there's any technical difficulties, and then the physician or provider sees them. So just discussions about that, and I can talk about the resources of where to find those. So what about the virtual care? What's the pros and cons? Well, it's really interesting. Some people might think it might be second nature or obvious, but it is good to point out these points just to prepare you to develop these in your own practice. And so virtual care remarkably has really had a much higher patient satisfaction than I think anybody would have initially thought. A lot of patients say that it's profoundly more accessible. They don't have to leave their house. They don't have to get a transportation. They don't have to take a bus to the office or the clinic. They're much more comfortable in the setting of their own home. They feel actually some increased engagement because of the one-on-one individual care. And looking into the computer screen and, you know, and seeing a camera, I mean, it works quite well for these patients, again, especially on a one-on-one. I know a lot of you are probably used to Zoom meetings with multiple folks, but really when it's one-on-one, it works quite well, and the patients feel very secure, many of them, in fact, the majority of them. The other interesting pro is that you can actually include the family and caregivers in the discussion. And so that really allows to discuss, what are their triggers, who are they hanging out with that you think is a negative for them, what are the practices that they're doing, are they, going and doing their meditation, are they practicing sort of their emotional resilience or cognitive behavioral training, or are they focusing on their 12 steps? It really helps to have family and caregivers involved, especially when discussing harm reduction strategies and the doses of their medications. And then, of course, because they're not in the clinic, there's a huge potential, or a lot less potential for viral transmission. And what about the cons? Well, technology problems are a real issue. I was almost late for this webinar because I couldn't get into the apartment that had good, reliable internet. So I almost suffered from that this afternoon. Really, there's a lot of difficulty with some of the older folks with familiarity with technology. Some of the older folks feel it lacks a personal touch. Again, that's a minority. Remember, a lot of the folks we see in Florida are in rural areas, and that's a real issue for broadband ability or Wi-Fi ability. And then, of course, privacy concerns. Is there going to be hacked? Can you get hacked? That sort of thing. So that's definitely a con. So concerning privacy and security flexibility, the Office of Civil Rights put out a bulletin and said what previously, you might have thought was non-HIPAA compliant is in fact quite HIPAA compliant. And they are okay with you using FaceTime, Zoom, I don't know why I didn't put it in this slide, Facebook Messenger video chat, Google Hangouts, or Skype. We're on Cisco WebEx, so that one's approved as well. They don't allow for Facebook Live, Twitch, or TikTok. So definitely that's a huge barrier. And then the other big barrier was 42 CFR Part 2 and states, you really need consent or disclosure, or you can't really disclose substance use disorder and the records associated with that. And SAMHSA states that this prohibition does not apply if the provider, and it's completely up to the discretion of the provider, determines that a medical emergency exists. And they really detail this quite well and explain that, hey, listen, if somebody's going to go into withdrawal, that's a medical emergency. And so there's really ways around now this 42 CFR Part 2 guidance. So that's two great hurdles that are now overcome and specifically shared by the federal government in these resources below in the slides. And I must say, it's very, very well done. I'm very impressed with the specific instructions from SAMHSA. The PDFs on this subject matter are 2 to 3 pages for each subject. It's very digestible, very easy to read, and very clearly pointed out with question and answer format. So what about increased, I talked to and said the DEA increased their flexibility on writing scripts via telehealth. Well, I just want to let you know that Schedule 2, so those are the most potent, that's Percocet, Dilaudid, OxyContin, 2 through 5 controlled substances can now be prescribed via telehealth visits without an initial in-person evaluation. And that's only during this public health declaration of emergency. And as I mentioned, as the cases continue, initially this was like 30 days, but every time, or 60 days for the declaration of a public health emergency. But every time it's been renewed, and I suspect it's going to be continued to be renewed probably for the next 6 to 8 months, or at least until a vaccine is developed. So the DEA is very plain, black and white, says two-way interactive communication system, specifically not the telephone, but hold on, there's a caveat to that. I don't want to get too complicated. But basically, two-way interactive communication, if so, you can write for Schedule 2 drugs, and it can be delivered electronically to the pharmacy and even via telephone as well. Now, the telephone can be used, in other words, just simple telephone call for initiation of buprenorphine. And that's because buprenorphine is really such a safe drug when you compare it to the illicit substances and even methadone. So as I mentioned, a telephone visit will suffice if you have an X waiver for buprenorphine. And we're going to kind of go over that multiple times so you kind of will get the message, certainly. Per SAMHSA, so when we speak specifically about buprenorphine, per SAMHSA, again, new patients and existing OTP patients, so that means in a methadone clinic, can be treated with buprenorphine and can be treated via telehealth and even just the telephone. As I mentioned, it only applies during the public health emergency. You still must be X-waivered. Again, it's a real shame that only 7% of our clinicians are permitted to prescribe the drug. Clinicians with the data waiver, if you do not work in an OTP or a methadone clinic, you still can use this modality to treat your patients, i.e., I don't work within a methadone clinic, but I'm beginning a telehealth service with a company, an established company, and I am outside of the context of an OTP, and you can still do it and write for patients with buprenorphine, again, via telephone or telehealth. I always mention pregnancy. I think we forget pregnant patients in opioid use disorder, and I think these are some of our most susceptible patients and most vulnerable and most likely underserved. I was very heartened on the last webinar to hear that one of the participants works in an OBGYN clinic that specializes in buprenorphine for pregnancy. And I just want you to remember that both methadone and buprenorphine are safe in pregnancy. Buprenorphine appears when you give buprenorphine to a mommy who is pregnant, when the fetus is delivered, they need 89% or 90% less morphine to treat their neonatal abstinence syndrome, 43% shorter hospital stay, and a 58% shorter overall duration of medical treatment. Again, that's for NAS. So there was questions yesterday is, what does buprenorphine do to the baby? Well, interestingly enough, buprenorphine and methadone, they're both opioids. Shockingly, opioids don't injure the fetus's development in any way. The only thing opioids do is the baby is born dependent on opioids. And that dependency requires them to be weaned off, and we wean them off in the ICU with specifically morphine. Heather Mercado asked, is Subutex better for babies rather than Suboxone? Heather, my answer is absolutely no difference, genuinely. That's an excellent question. Remember, Heather, that Suboxone is a formulation. The main ingredient, of course, is buprenorphine. And then in the sublingual tablet and or film, there's a little bit of Narcan. And what's important for all providers to understand, and this is shocking because a lot of providers don't understand this, is that Narcan sublingually, which is under the tongue, or absorbed in the GI tract, is inert. It does nothing. So it doesn't do anything, to the baby either. I don't even know if it crosses the placental barrier, frankly. But the important thing to understand about Suboxone is the only time that Narcan is active or actually works is if the patient takes that film or that tablet, breaks it down, boils it down, and injects it. From Joanna, that's privately, sorry. Excuse me. Okay. Oh, that's a great question. I'm going to stop here and just focus on this question because it's super interesting and I can talk about that. And that is a very fair question. this person's question is, why am I stating that medication is the primary modality? In my program, we use it to, quote, buy time for people to become more stable. We focus on treatment and psychosocial stabilization, and MAT helps to provide that. That is a great point. I'm going to tell you, I'm just going to pull some stuff up here just to help you out with that. What I'm trying to express when I say MAT is the primary gold standard is I can refer you to an incredible, committee's conclusion. And that committee's conclusion is the following. The committee is the National Academy of Sciences, Engineering, and Medicine. And I want everybody to understand that no doubt about it, and you'll hear that other people will differ on this, those are opinions, but the clinical evidence is that MAT saves lives and keeps our patients alive during treatment and psychosocial stabilization. But there's this misconception that MAT should be only used for a short period of time. And that is, I understand, very debated in the addiction treatment community. But the experts that write the literature and are nonprofit experts, specifically for medication, specifically for the National Academies of Sciences, states, period, that FDA medications to treat opioid use disorder should be thought of as long-term retention. In other words, long-term retention on medications to treat opioid use disorder is associated with improved outcomes. They make this statement, and I'm going to be careful about this. How much time do we have here? We have 30 seconds, but I will go about 1 to 2 minutes over. They make this statement. They state that a lack of availability of behavioral interventions is not a sufficient justification to withhold medications to treat opioid use disorder. In other words, again, it really is a primary modality. I agree with you and the person who commented on this. I agree with you that they desperately need psychosocial stabilization, but the truth of the matter is that can take a very long time. And many times the patient can never get out of that environment or those negative social determinants. So we are very comfortable preaching and stating, and the literature backs it up, that you should stay on MAT long term as needed. Some folks do great on it for 6 months to a year. Others do great on it for 2 years to 3 years, and others will need it for a lifetime. And in fact, I would argue that using it only to, quote, buy time is a bit of a stigma of patients being on it. So I certainly don't mean to be argumentative. I'm just telling you that, this is the overview of the conclusions and, in fact, the standard of care now. I'll read this one also, and this is a very, very strong statement from the National Academies, and it says, MAT is effective across all treatment settings studied to date. Withholding or failing to have available all classes of FDA-approved medication for the treatment of opioid use disorder in any healthcare or criminal justice setting is denying appropriate medical treatment. And so, that's essentially saying that at this stage of the game, this came out in March 2019, if we are not offering our patients MAT who suffer from opioid use disorder, we're essentially creating substandard care, which could also be interpreted as malpractice. So that's a very strong statement. I don't mean to be an obstinate individual. And really, we've got to get patients on it. A lot of people feel like, this is a medication that is treating the changes in their brain chemistry. Those changes in the brain chemistry are real. Does psychosocial therapy, cognitive behavioral therapy, and 12 steps help? Absolutely they do. But until they are improved and can really get out of that situation and really be stable without medication, we are not asking people to pull people off of medication. because the truth is medication save lives. Is it for every single patient that suffers from opioid use disorder? No, absolutely not. It's individualized. Some patients do great for 3 months or 6 months on it and come off, but it's not one standard for all persons. So I hope I got that across. What does the impact, somebody stated, for intranasal naloxone have on an unborn baby? That is a great question. I'm really embarrassed to admit that I'm not sure if intranasal naloxone crosses the placental barrier. I have to check on that. That's very embarrassing, and that is an excellent question. Bravo to you, Susan. I can tell you this, though, Susan, looking at it from a clinical emergency medicine perspective. If that fetus is within the mom and the mom is suffering a fatal overdose, then the baby is certainly going to die. And so, in one respect, it almost doesn't matter what the harm is to that fetus. I can tell you the harm is much worse if we don't reverse the overdose to that patient. So I guess that's the best way I could explain that. But I'm being very intellectually honest and admitting that I don't have that answer specifically. With isolation being so detrimental to addictions, oh, that's the same. We talked about that. Let's see here. Somebody mentioned it's the same as treating a diabetic. Each person is different based on body chemistry and situation circumstances, which can change. I absolutely agree with you, Tanya. Again, I'm not here to say every single patient needs MAT. I'm just trying to say that MAT has been ignored for so long, and I really feel that that's because of the abstinence community. And there's no doubt about it that when you put a patient on MAT, their fatality rate drops by 50%. And if I told you that all of the medical interventions that we do in hospitals for heart attacks, stroke, nothing reaches 50% diminished fatality. Nothing. So it's an incredible shame that we haven't been more focused on MAT. And I really do believe that the patients we treat really suffer when we don't offer it. That's an excellent question. Somebody mentioned clients often regress at the end of the treatment, no matter the length of care. Absolutely, positively. That's some of what I was trying to express with the first person's question. What individual standards are there to decide when medicine care should be over or extended? Kelly, amazing question. There are no standards. It really is individualized. And frankly, if I had a family member who was on MAT and they were, I'm going to stop very soon, but hold on. Let me just explain something. I should have said at the very beginning of this, really, Kelly, it depends on what we define as recovery. And really, if we could talk about what's recovery, and really we could get 30 different answers. But truthfully, and this is up to debate, in most of the newer, more progressive treatment modalities, we feel that recovery is simply a process of change where people improve their health and wellness, they live self-directed lives, and they're striving to reach their full potential. So in that sense, Kelly, remission or recovery should not be taken to mean complete cessation of opioid misuse. But instead, we should acknowledge that a marked reduction in use is a very worthy goal. And really, Kelly, that's why we're pulling back on UDSs or urine drug screens. Even the statement that, they quote, peed dirty, that's stigmatizing in and of itself. When a diabetic has a donut, do we say that they're a dirty diabetic? Do we say that they're a terrible patient? Do we remove their insulin? No, we wouldn't even conceive of doing that. Do we remove their oral meds? No, but we do it all the time for patients who suffer from opioid use disorder. And we really just sort of need to change our paradigm to really continue to save lives. Thank you all. Again, I want to reiterate that, could you show everyone's questions to everybody? You know what, Kelly? I wish I could, but some of them are sent privately. So I think, personally, I want to just, I'll just read them out. And I think some of those folks might not want to share their name. But I really enjoy addressing you by name because I think names are very important. But if they send them privately, Kelly, I think I should maintain their privacy, if you all understand that. And again, really, I just want to reiterate, I don't think that I know it all. I don't mean to say that what I'm saying is the absolute truth. The only thing I do as a physician and a patient advocate in this treatment modality for these treatments, for these patients, is to share with you what the majority of the literature is now expressing. And that's it. It's just what the literature says. It's what we call in medicine evidence-based. And so, we don't really jump to conclusions until we have large evidence-based literature. And really, the literature shows, that MAT really should be a primary modality for the majority of patients, and then address them on an individual. Somebody expressed that the program's a bit confusing and they may be sending them privately by accident. I almost did this myself. Okay, that's fair. And Kelly, I agree with you completely. I wish all of them are shared, and maybe we'll do that as an improvement for the future. But I promise you, I'm reading them out. One of them was recently, do you think that there should be a time limit on MAT? And how does this coincide with harm reduction and MAR? I'm sorry, I don't know what MAR means. I think I answered the question related to time limit on MAT. How does it coincide with harm reduction? I think that's kind of an interesting question. I really believe, somebody shouted no to the time limit, and I'm a proponent of that personally, Tanya, as well. But I want to, medication-assisted recovery, interesting. Okay, that's a term I really haven't seen much before. I appreciate that. I am a proponent of not instituting a time limit for MAT. Typically 12 steps, but not always. Thank you, Steve. Okay, that's excellent. That I'm a huge proponent of. I think the 12 steps are really what Stoicism is. Quite frankly, Stoicism is a 2,000-year-old Greek philosophy that really is based on emotional resilience and dealing with trauma and tribulations and difficulty in life. And really, the 12 steps are really a distillation of Stoicism. So I'm full bore into 12 steps. I think they make people genuinely resilient and self-aware people. I think they make them better human beings, but I just beg for them to be applied with medication-assisted treatment. So I think I'll stop there, folks. I really love the interaction. As you can tell, I get even more passionate, and I appreciate the responses. And let's take 5 minutes, and we'll come back.
If everyone can be back at 2:34, around 2:34, that would be great. Thank you. Okay, I'd like to welcome everyone back from break. Are you ready to get started, Dr. Wall?
Yes, I am. Yes, I'm just typing some responses. Okay. All right. All set. Just by the way, I had some questions on Stoicism, and one of the best introductory books to it is Ryan Holiday's The Obstacle is the Way, and I included that in a discussion with Steve Farnsworth in the question and answers. It should be viewable to everyone. All right, so we're going to move on here. Just talking about buprenorphine in pregnancy, we covered that. I do want to say that buprenorphine in pregnancy is not the only modality. Again, methadone works quite well, and some patients apparently really prefer methadone over buprenorphine. And so I just wanted to make sure that I wasn't sort of down-putting methadone. I was just trying to share with providers that are writing for buprenorphine that it's a great treatment modality for those that are pregnant. But some moms, just because of the need to experience withdrawal before getting on buprenorphine, they would rather not do that, even though it's really only about 12 hours or 8 to 10 hours of withdrawal. Methadone is a great modality for those patients. Again, it just involves going to the clinic every day, and that can be a stressor, but not always, and we'll talk about it. Okay, COVID-19 and pregnancy. So some questions are also, are pregnant patients at a higher risk for COVID? So this isn't really a COVID course, but since we're talking about it, no, pregnant patients are not at a more severe, they don't experience a more severe symptomatology. Even though pregnant patients tend to be a little bit immune suppressed, they do quite well, and basically they really just fall normally into the age ranges of those. You'll see that COVID really responds to patient ages quite differently, and they're no different. They fall into their normal age range for risk of severity for COVID. Can COVID pass through breast milk? No, it cannot. It appears there's no transmission through breast milk. However, if a mom did have COVID or was actively sick with COVID, we would basically recommend that do proper hygiene on the areola and nipple area, most likely breast pump, and then give the baby the breast milk that way. I want to also reiterate that, our fears of COVID in the pregnant patients were initially a bit overblown, and there was a lot of separation from mother and baby, and we are not doing that anymore, and that is not promoted just because physically the touch and consoling and succor that a baby receives from the mom in the perinatal period just after delivery is very, very important to the baby's health and well-being. And then does COVID-19 affect a fetus, the unborn fetus? No, according to our research, it does not appear to pass through the placental barrier, and neither during labor or delivery. So really good news as far as that's concerned. What is it that women have shared and expressed concerning how poorly they've done during this COVID-19? And really, again, we're focusing on the sheltering in place being an enormous trigger for these patients. The ways, the one states that the ways I acted in addiction, I now see coming back, but I have better coping skills now to deal with those feelings. Again, in blue highlighted, isolation is a major trigger, and it helps to be able to go out and get out and walk, to have a wellness type of routine. Despite that it's kind of a fad for somewhat wealthier people, I have been really pushing meditation for my patients and even those within my close circle of influence. It's been enormously helpful for me as a physician, avoiding burnout and really instilling much more meaning and purpose to avoid burnout. Obviously, you all are well aware that substance use disorder treatments are patients are frankly some of the most complex patients that we deal with. And frankly, it does get tiring, and we all are human beings, and we can suffer burnout. And meditation has really helped me over the last 2 years. And I only meditate for 10 minutes a day, sometimes 20. I'll do one time in the morning and one in the afternoon. But I use these little basic apps. I like the Daily Calm. There's a number of them out there, and they're just wonderful. And they even teach you how to meditate. So I've been doing this for substance use disorder patients. They've expressed that having tools to find employment really helps them a lot. I work for a coalition. I'm their medical director in Central Florida called Project Opioid. And we've shifted gears and been really offering resources to find employment because I discussed how not having a good job and not having a meaning and purpose from your job is so detrimental to patients. So really help with finding employment is a big positive. They want providers to know how hard it is to have the same day over and over with their children in isolation. I think we forget that. I do not have children, and so I can't imagine the stress and struggles to keep children entertained and safe in the home, and it's really, really quite tough on them. So just pay attention to that and acknowledge that. And then, of course, as always, I walk around with my hospital ID badge, has a LOVE pin on it, a love pin on it. It's just to remind people to be patient, have empathy, take a breather, express love for those patients that you're taking care of. Remember, patients we are in the healthcare industry, and our job is to provide care and not judgment. And it's very difficult for us to do that because as human beings, we tend to be judgmental social animals. But really, we need to forego that and move that part of our personality aside and just care for the patient in front of us. No matter how manipulative we feel they are, we have to remember, and I always coach myself and say, it's part of the disease process. It's part of the disease process. So I'm more strengthened to treat the disease. Some clinics are handing out PPE for the patient and the kids, and moms have expressed that they really appreciate that. And then, frankly, of course, it seems like I shouldn't mention this, but of course we always do have to mention it. Just be very wary of your own biases. One of these expressed that a nurse who was doing a drug test on them who wasn't from a OTP stated that if an addict's lips are moving, then she's lying. It made the patient feel like dirt, and like she was less than dirt. I've even had some private messages today from patients expressing how fortunate they are to hear somebody preach against stigma even within our own addiction treatment community. So just be wary of your own cognitive biases. Okay, so we talked about buprenorphine and the new flexibility with buprenorphine, and somebody would ask, well, what about methadone? And per SAMHSA, it's not that much different, but per SAMHSA, if you have a patient who is an existing patient at your methadone clinic, they can continue to receive methadone treatment or visits and assessments via telehealth. But SAMHSA was very clear on saying that the requirements for an in-person medical evaluation must remain in force at the beginning. The reason for that is that because methadone is a very potent drug and it doesn't have the safety profile that buprenorphine has. So again, to be very clear, you still need that initial in-person visit. The maintenance can be done via telehealth. This is take-home dosing. This is very new for these clinics, and this has previously not been done, but they are authorizing, if the provider determines that a patient is stable, quote unquote, that patient may receive 28 days of take-home doses of methadone. If they're less stable, they might be able to take home 14 days. And then there is home delivery allowed. Interestingly enough, the DEA has authorized a staff member, the National Guard, or even a law enforcement officer to make a delivery at the doorstep in a lockbox approved. I spoke with some OTP providers here in Florida and the Southwest Florida region, and they said that they're not necessarily doing that, but if a patient does have active COVID, they are allowing a trusted proxy to come and pick up the medication for them. So all sorts of new modalities that you can get into. Of course, I wanted to focus and never de-emphasize the importance of counseling with MAT. And COVID has, in fact, hastened a lot of states to ease linkages of counseling and MOUD. And so they definitely, as we've discussed, they allow these prescriptions via telehealth, and then they allow and encourage counseling to be provided to patients as necessary via telehealth and telephone. And as well, we're really encouraging that counseling over telehealth as well as even peer support. And we'll talk about that more. Importantly, online group formats should be formed. We're going to talk about that briefly as well. And then SAMHSA has some incredible resources for online hotline support groups. And you can find those easily with the information that we provide at the end of this webinar. And so, again, some of this seems like maybe it's common sense, but I want to state, the benefits of digital peer support. Again, we're going into peer support. I'm a massive proponent for peer support specialists. I think that to have that shared understanding of addiction and the things that predisposed people to addiction, they understand the environment that set that patient up for addiction, their ability to counsel and really provide a lot of empathy because of that shared experience, I think cannot be overestimated. So I'm a huge proponent. When we started our buprenorphine induction program in Southwest Florida at Lee Health, it was very imperative for us to get a peer support specialist. They were very difficult to hire and find. And the right one is the right one, and it's difficult to find that right one. But we noticed that we really needed them at all the emergency departments, and really using them digitally expands their sort of geographical reach. The other interesting point is that some peer support specialists really allow the patient to call them at all hours. And so there's really no time limitations. So there's no real scheduled set, 9 to 5 meetings. It can be after or in the evening, and that really caters to the patient and their needs. Obviously, it's outside of the clinical environment, so a lot of times that feels better for the patient. They don't have to worry about noise or, that there's noise generators in the hallway, so nobody's going to hear their talking to their peer support specialist. So obviously it expands the reach. And then, of course, they can reach hard to reach groups, such as rural residents. One peer support specialist can cater to, somewhere 50 miles away in a very rural area of Florida. They can access hard to reach groups and those homebound adults or even homeless persons. So really quite beneficial. What about digital peer support? Is it really substantiated in the literature? And absolutely it is, in fact. You can see references in the literature below, but these studies have been done to sort of support what is the feasibility, what are the effectiveness, is it accepted, and they found definitive reductions in risky substance use behavior, very high levels of satisfaction and perceived benefit from the patient, and really this bottom one is the most important. It keeps them, having a peer support specialist at their side is much like an advocate or a sponsor for NA or AA, and it really keeps them engaged in these services. All right, so shifting gears a bit to harm reduction, please don't forget the importance of naloxone as a harm reduction strategy. I wanted to put on this slide, don't forget naloxone co-prescribing, but really it's not co-prescribing, it's really co-dispensing. We really have the ability now to gather kits and be able to dispense them via standing order programs. I'm going to talk about the one I'm involved in. And what is a standing order? A standing order means a physician writes a two-page sort of protocol, and then the dispensing pharmacist or the dispensing person can dispense that medication under my name to any patient or family member of the patient, and that's called third-party prescribing. And without sounding like I'm talking or promoting myself too much, I was personally involved in the legislation in 2015 and 2017 and the wording of the legislation. I'm very comfortable with the protection that the state gives me in a Good Samaritan type of role. And I've put my money where my mouth is and wrote numerous standing orders for all 4 outpatient pharmacies associated with the Lee Health System in Lee County, Florida. That's Fort Myers area. And also with Project Opioid, which I'll mention in just a few slides, I've signed a standing order for them. Now any patient can go to CVS or Walgreens and receive Narcan without a specified prescription because the physicians overseeing CVS and Walgreens have written for a standing order. And this is incorrect. It says naloxone is available via any pharmacy standing order from the state surgeon general. Interestingly enough, the state surgeon general, I wish I were the state surgeon general because I would have written it for everyone. But the standing order that the surgeon general signed is kind of cute. It's just for first responders. So any first responder can come in and get Narcan to kind of carry around on their own. I think every citizen should have Narcan. But importantly, as Karina just put up in the chat here, this green box is Amanda Muller. She's an incredibly passionate advocate for our patients, and she's been simply fantastic in getting Narcan out into our communities all over Florida. She works for DCF, the Department of Children and Family, and she's incredibly proactive, and she can set you up with kits. This next slide is really just to kind of show that there are definitive reports of increased overdoses following COVID-19, of course, for the numerous reasons that I discussed earlier in this webinar. And it's more important than ever to really promote harm reduction services, mainly naloxone. In our hospital system, in the emergency department, interestingly enough, we teach harm reduction strategies such as safe needle injection. Yes, we do provide that for patients. We also teach them to always avoid using alone, always carry naloxone, try tester shots, avoid sharing equipment, use a new filter every time when injecting, use sterile equipment. We teach them how to clean their equipment and protect their veins. Because harm reduction and even needle exchanges, it's not big in Florida, but I believe it will be in the next few years, really prevent HIV and hepatitis C precipitously. And then they also prevent heart valve infections, which is called endocarditis. And that's a very expensive, very prolonged hospitalization for a patient that suffers an infection on their heart valves, and they usually require heart valve replacement surgery. So this is Project Opioid. I just want to focus on it. I'm not trying to, it's kind of a shameless plug, but Project Opioid is a coalition in Central Florida of business leaders, sheriff's departments, faith leaders, and politicians. And I signed a standing order. Let's see here. William White paper on recovery coach, sponsor, and addiction counselor, and their role. Clarity shows the role of each in a person's recovery. Thank you for sharing that, Tanya. That's excellent. And yes, the webinar will be available on demand. Yes, Tanya. Thanks a lot for sharing that. That's great. Corinna put that up. Okay, but can you please, Corinna, put projectopioid.org? That's the website, and you just click on Get Naloxone, and your patient, any patient, can fill out this request. And thank you, Tanya. And the request for naloxone, and we will send them a box of naloxone with instructions mailed to the address that is provided. And I want to just point out that administering naloxone in COVID-19 is really not as scary as some law enforcement places are trying to make it. They are trying to express that we shouldn't be doing it because of the risk of COVID-19. I would argue against that specifically. We really want to point out that there really should be no delay whatsoever in administering naloxone to those suspected of an overdose. Administration of naloxone will entail, of course, a brief period of being less than 6 feet from the person. And I'm not trying to be cute or funny here, but the patient is not breathing, so they're really not spreading viral particles, even if they were profoundly infected with COVID. And so you can safely inject into their nostril. You can certainly use face protection and gloves if available, or just wash your hands following the administration of it with regular old soap and water. Yes, regular old soap and water kills all COVID particles. And then, of course, if there is no response to naloxone, to give the second dose in 2 to 3 minutes. And so services of new patients, we just wanted to briefly I wanted to cover just some ins and outs of starting your telehealth services. Really, these are just some tips to do so. It's better, obviously, to use two-way video conference calling. Very easy to set up with Zoom now, or any WebEx type of program. You can get a mailed consent form. It can even be completed over the telephone or Zoom, the consent, as I discussed before. Any behavioral health intake and or counseling, of course, can be completed via telehealth. And then patient engagement in the weekly telehealth groups really helps to keep them engaged and retained. And here's some quick tips on it. Really just communicate and keep an open line of communication and transparency with your staff and patients regarding, any issues that arise or any improvements that you find. Really, somebody in the office should develop clear, written, very easy instructions for staff and patients on how to utilize these Zoom meetings. How to communicate the information to patients should be sort of protocolized. And then, of course, how to navigate Zoom and how to sign in. I definitely recommend a test run. Karina did a test run with me prior to giving these 3 webinars, and it's very, very useful. And really, somebody should spend just 5 to 10 minutes with the patient beforehand, and then there's no kind of wasting of time. Your provider can come in and see the patient, and it really diminishes frustrations. And then, of course, give them a landline. Well, there's no such thing as that almost anymore, but a number to call if there's any difficulties. That helps a lot. And then really, if you're doing group telehealth meetings, I would start with smaller groups first. A big, greater than 10, 15 people can get a little bit clumsy. And so really try and work any of the kinks out with a smaller telehealth group. And then during the appointment, really treat it as a genuine meeting. Go through with the formal introductions. Always assess the patient's comfort, and really keep engaged with the patient. That means good eye contact into the camera. I know we all love to stare at ourselves and our blemishes and how horrible the lighting is on our little video piece, but really try to remember to engage by looking into the camera on your computer screen. And then this has happened to me recently. An AirPod fell out of my ear, and I went kind of scrounging around for it on the floor and didn't really explain what I was doing, and everybody wondered. And so just be mindful of that. It's easy to do that immediately, but remember you're still on camera. And so if anybody interrupts or comes into your office while you're discussing things with the patient, just excuse yourself, or let the patient know what's happening so they're not watching you do some sort of strange dance searching for your AirPod on the floor. And then after, definitively ask for feedback. Oh, thank you for that. South Florida Wellness Network is also a naloxone distributor in Broward. They train and give free of charge to community. Bless you. That's excellent. Thank you for sharing. Ask patients for feedback, debrief with staff, and that really allows for continuous improvement. And then here's just a slide showing you, validating that there's numerous opportunities for states via Medicaid and Medicaid reimbursement. The federal government is mandating coverage and payment parity for telehealth. They are mandating all of the things I discussed. I don't need to reiterate them here. They are establishing temporary Medicaid telehealth service codes. And some states are amending state licensing requirements to expand the pool of providers allowed to deliver these telehealth services, including out-of-state providers. And so remember that we are a republic, and there's states' rights, and then there's the law of the land, which is the federal law, and oftentimes they don't come together or correlate. Florida specifically has deferred to the federal government in these actions, and really whatever the federal government is allowing, Florida is apparently allowing. And this was sort of just announced, alluded to really on June 17th. First Lady Casey DeSantis has come out and stated the changes in ACA, and it really reiterates what I was just describing as far as Medicaid services and the surge in telemedicine claims. They've waived prior authorization requirements for all behavioral health services covered under the Medicaid program. The last line show you they have lifted limits on prior authorization, which allows practitioners to more quickly provide for some of the longer acting medications, injectables, as well as buprenorphine. So really, Casey DeSantis has been, although I would possibly argue, obviously, well, some of us would agree that Florida is a little bit behind the eight ball and behind the times. Casey DeSantis, I think, has been really a welcome presence in her at least focusing on mental health and substance use disorders. And then here's just evidence of the recent action that Medicare has done through CMS. An important one here that I would love to circle or highlight is the third one down, and that states, per CMS, providers licensed in one state may provide services to Medicare in other states via telehealth. And the flexibility allows providers to leverage out-of-state telehealth networks to meet this demand. Sherry Marquis asked, what about alcohol dependence and MAT? Truthfully, I have started patients on oral naltrexone for alcohol dependence. There is a decent amount in the literature that shows it helps alcoholics diminish their binges. And so, you can Google that, oral naltrexone, and it works relatively well for those suffering from severe alcoholism. I would definitely endorse it. Of course, there's not a great replacement therapy for alcohol, like there is with buprenorphine and methadone and such, but definitely oral naltrexone seems to assist quite a bit. Some people will concurrently treat them with benzos, definitively to detox, and that would be considered MAT, but I am not a big proponent of detox. I think it's a little bit like stigmatizing, and I really think that we should keep patients more on medication. Sherry, that's a fantastic question. Her next question was, what about cocaine psychoses? Cocaine psychoses, in fact, is treated in the emergency department if you are psychotic or having a sort of a schizophrenic break or hallucinations with cocaine. We treat with heavy-duty benzodiazepines, which is basically IV Ativan or Valium. And that's just during the acute phase. And the same goes for methamphetamine toxicity. But truthfully, Sherry, and unfortunately, I'm very nervous for our communities because as methamphetamine abuse becomes more prominent, there really is not a lot of literature on MAT to treat long-standing methamphetamine dependence. Are there non-narcotic treatments? Non-narcotic treatments as far as MAT, I will tell you that I don't know if that's applying to cocaine or methamphetamine or just opioid use disorder. But of course, the most prominent non-narcotic treatment, which is one of the 3 FDA-approved medications for opioid use disorder, is injectable naltrexone, and that's also known as Vivitrol, and that blocks the effects of all opioids should the patient utilize opioids. So it is considered MAT, and it is absolutely non-narcotic. So those are good questions, Sherry. Really, this kind of brings, it's 3:05. Technically, I have 10 minutes to go, but officially, we wanted to end at 3 o'clock and respect everybody's time. These are the additional resources that I wanted to discuss. SAMHSA, CMS, when this comes out, or you can take a picture of it on your screen and utilize it. They're very, very well done. I would say the best overall site is this website down here at the right-hand corner. 4 is called Foundation for Opioid Response Efforts. And everything that I have discussed came almost directly from 4's website. If you click on 4fdn.org and you go to resources, there is about 20 webinars, each are 1 hour long, and some white papers that are fantastic, describing everything that I'm describing here. A cheat is to either watch the webinar at 1.5 speed on your YouTube viewer. You can go to the little, looks like a gear for settings, and increase the playback speed to 1.5 speed. And you can also just use the slides in a PDF fashion and zoom through the slides as well. So I covered every one of those incredibly well done webinars. And I really suggest that you all go there and just look at their resource page. It's just been fantastic. And of course, FADA's website is very helpful as well. And perhaps we can get these things on FADA's website additionally. And then these are just official references. I want to thank you all very, very personally for what you do for our patient population. Please continue to have a passion. What you do matters to each and every individual. There are days that you're going to be run down, and there are days that you're going to be burnt out. But please remember, and you might think you're not making a difference, and I want to tell you you're making a difference at each individual level. So please stay strong, stay vigilant, stay safe, and thank you so much for your attention. Here's on the left-hand side, here's my email. I'm checking my spam because it'll go into my spam. And then I'm at GatorDoc on Twitter. So thank you very much for your attention, and thanks for all your energies and passion and your time and your talent.
And Dr. Wall, we'd like to thank you as well. You've shared a wealth of knowledge, and we've had great comments and response from our audience. So thank you for your time. If you guys want to take a quick screenshot of the slide that I have on the screen right now, it has all of his information. So we thought that would be helpful. When we end the webinar today, you're going to be directed to our FADA website to complete the evaluation form. It's very important to get feedback from you. We love your feedback. If you have a FADA profile already created, you just need to log in to complete the evaluation. If you do not have a FADA profile already, you will need to set up one by clicking on Haven't Registered Yet. You can sign in as a visitor, and it's free of charge. Once you sign on or log in, you're going to be prompted to complete the evaluation. A second opportunity will also be given to you. You'll receive a thank you email with the link in about 30 minutes. If you do not get the thank you email, it's because we probably do not have a profile set up for you yet. So you'll need to set that up, or you used a different email address than what we have on your profile. So if you do not get that link, you can always make a copy of the link and post it in your browser and complete the evaluation. The evaluation closes on midnight Tuesday, June 30th. Once you submit the evaluation, you will get a message indicating that your evaluation has been submitted. For licensed healthcare practitioners, make sure you can include your Florida license and prefix so that we can report your attendance to CE Broker. Again, this process can take up to 30 days. So once you complete the evaluation, it's not an automatic. Please be patient. And also the presentation and recording will be available on our website within 30 days. Once we do upload your credits, we do not email a statement of credit after we verify your attendance and that the evaluation is completed. We do post those credits in your profile under professional development. And again, it takes up to about 30 days. And we also want to thank our audience for participating in today's webinar, and we'd like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Dr. Wall, did you have anything else you wanted to add?
No, I just wanted to, no, I did not. I just wanted to thank all of you for attending, and thank you for your comments, and please feel free if you have any dissenting opinions or comments that could be viewed as negative, please send them my way as well. I can take it, and it only makes me a better presenter in the future for you all. So thank you very, very much.
Thank you. Have a great rest of your day, and please hold for the evaluation.